Okay, let's have a discussion on like let's say, individuals that have like disc pathology,
Mm,
right? Okay, because now that we have the reverse hyper program out there, like we're getting a huge influx of people reaching out saying, "Hey, I have this pre-existing pathology at L5S1, L4," right? Like,
hmm
and people are going like, "Hey, it looks like this is a program that I should be doing," which they are correct. It is a program they should be doing, right? If you think about the reverse hyper machine in and of itself, like Louis Simmons, who invented that and then patented it, right? Like he started off doing the training with pathology in the spine. So he had a
Right.
fracture, he had discogenic stuff. Like he doesn't say that, but like obviously, anytime you have pain going down your legs, it's going to be discogenic, right? So he actually started. And so long story short, like if you have that pathology, like the reverse hyper is probably the safest setting for you to start to actually like load the spine. That's the reason why we essentially went through the programming and made the programming highly specific so that individuals get a point B spine from the program.
hmm
With that being said, for individuals who have a pathology in the spine,
hmm
maybe they have acute to chronic discogenic stuff, right?
hmm
They need to start loading, for like
hmm
we would agree,
hmm
right? Can you kind of like start to walk us through like just I guess maybe like the disc behavior when an individual has like a disc bulge, not a herniation, but
hmm
like a disc bulge, right? And kind of like how you have to find specific like entry points
hmm
to be like can is that enough to pass off to you at this point?
Yeah. Well, I mean, we sort of had this discussion in the last couple of days, just based on some case-based stuff. So maybe we should uh, set the stage a little bit more with like some point A information. Um, and so I'll let you kind of take that. Like just and the reason why we got into the discussion about what we're ultimately going to discuss in this video is I think generally for those that have dealt with clientele that have disc-based issues, um, very difficult to deal with in the clinical setting, only um, because of the obviously the complicated nature of what is going on. So they don't always show up exactly as they are described when we talk about them from a management perspective, meaning like generally it would be, well, discs tend to hurt more in flexion, so we should be doing more extension based stuff. And but that's not always the case. Sometimes they hurt in extension, sometimes they hurt in both. Um,
Hmm.
Sometimes the symptomatology that starts to show up down the leg occurs when you do this particular movement, which doesn't exactly add up to, maybe necessarily what we have been taught or know. So the idea is that when we're dealing with these particular scenarios, they're not they're not very easy to kind of cookie cutter. There's no real approach. And so you were dealing particularly with client who had had some disc pathology. Um, the disc hurt in certain ranges of motion, more so in extension, not necessarily flexion, although there was some flexion intolerance at some point, if I remember correctly.
Correct.
And now there's some difficulty in engaging some of the lower limb musculature, hamstrings, some glute stuff. And when those are engaged, or when the client is or the athlete is specifically cued to engage those, they do get some symptoms. If I'm kind of summarizing that correctly. And so the discussion that we were having is based on what you had previously mentioned, which is obviously we need to get some loading into those lower limb tissues, the lower limb anatomy. Obviously, we need to get some loading into the spine. How do we do so? Like, and so we were having this discussion whereby the way that I would approach this, which um, is again very general, the use of heuristics basically is number one, if you start with a position, whatever that position might be, lying prone, lying supine, a bridge-based scenario, a reverse hyper-based scenario, where you're trying to get the client to engage those particular those muscles, and the symptoms emerge at some point, and maybe they get to a level where that stops them from being able to continue. Well, that kind of formulates your baseline. So now you have to take into consideration, okay, that's my baseline. What was in my baseline? What spine position was I in, or did I have the client in? What cues did I use? What movement were they doing? And what was the loading parameters that I had associated with that? And then you kind of have to change those things to find out where, as I kind of was speaking to you about it, like you kind of have to find out where the door opens, because what that's telling you right now is the nervous system is closing the door. It's not allowing you to access what you want to access, because there's an output that you want to get out of that. The output is I need to get these tissues to feel some of this force, because I need contraction through here.
Mhm.
And so the one that I would change first and foremost is spine position. And so using that heuristic, we go and we say, okay, well, what position was the spine in?